Chad Porter, and I'm doing the Category 3 SOT video. We're going to start off with the prone leg length. I'm going to be standing here. I'm going to bring my patient's legs out, have them hold. Okay, and then I'm relaxed. I'm going to bring them in, and I'm going to look at the medial malleolus. Whichever one is higher, that's the leg that is the short leg. We'll say our right leg is short. Next, we're going to do the glute fiber analysis. Patient is prone. I'm going to start with my thumbs as area 5, and I'm going to place that on the PSIS, and I'm just going to go out about an inch 5 times and ask the patient which one was the most tender. She's going to give me, say, 3. I do the same thing on the other side. 5, 4, 3, 2, 1, going along the iliac crest. I then ask which side is more tender. I then correlate that to the lumbar vertebra, and then I use that with the Lovett brothers relationship to the cervical wedge. Next is the indicators. I'm just going to palpate my patient and ask them if any of these are tender. We'll start out with the calf, go to the hamstring, the glute, erector spinae, and then we'll have the patient turn, and I'm going to come up and do the temporal sphenoidal line. I'm just asking if the patient, if it's sore, or if any of these are sore. And as we're blocking, we're going to monitor those areas to see if that tenderness goes away. Next, we're going to do the step out, toe out. This is both therapeutic and diagnostic. I'm going to bring the short leg out about 45 degrees. I'm going to rotate the toe out. And I'm going to hold that for 15 seconds and then slowly bring it back in. Wait 2 minutes and do it again. If the pain gets better, it's sciatica due to piriformis. If it gets worse, it's a sequestered or fragmented disc. And if the pain stays the same, it's a lumbar subluxation or a disc herniation. Alright, so category 3 blocking. Patient is prone. This is a passive blocking, which means the patient does not help me. This side was the short leg. I would ask my patient if they have any knee problems. Say no, so then I can bring this up. Short leg side is going to go at the greater trochanter, and it's going to be obliquely inferior. So it'll go like that. Long leg side is going to go at the ASIS inferior. So it'll be like that. Maximum block time is 30 minutes. Yeah, and the goal is to decrease pain. So next I'll go to my blog augmentation. First is the posterior iliofemoral ligament. My indicator is a rotation restriction. We'll say that there's a rotation restriction here. I'm going to stand on this side. I'm going to double thumb contact 1 inch superior and posterior to the greater trochanter, and I'm going to thrust towards the opposite obturator foramen. So it'll be here, thrusting. Next is the lumbar vertebral derotation. So the indicator would be cervical TVP tenderness confirmed with lumbar palpation. I'm standing on the side of the spinous process rotation. I'm going to bend the knee, and I'm going to contact the spinous with my thumb, and I'm going to push in a line of correction for 5 seconds, and I will do this 3 times. Next is the lumbar inferiority lift. The indicator is going to be cervical TVP, cervical spinous process tenderness, just kidding, confirmed with a lumbar palpation. I'm going to stand on the side of the inferiority. I'm going to have my patient grab the head of the table on the inferior TVP side, and I'm going to contact the inferior with my thumb, my superior hand, and I'm going to have my patient inhale and hold and traction their body superior while I push superior on the TVP for a count of 5 seconds. Okay, and I would do that 3 times as well. Next is the acetabular goading. Indicator is going to be acetabular pain and or sciatica. I'm going to bend the patient's knee and hip, and I'm going to put it into external rotation and internal rotation, and I'm going to goad the femoral head. Sorry. And I'm going to do that in internal and external rotation. Next, I guess, is orthopedic blocking. The indicator is cervical TVP tenderness. I'm going to take out the block on the side of the spinous rotation, so we'll just say it's on this side. Patient will now rotate towards the high side of the pelvis and do this for 3 to 5 minutes. Sciatic traction, indicator is sciatica. Have my patient grab the head of the table and traction superior, while doctor traction sciatic leg inferior. I think I can put this back in. And I'm gonna hold that for, about 5 seconds. Until pain is gone or there is no more improvement. The assisted, it's the same thing, except I'm gonna have an assistant pulling on this while I contact the spinous process at the level of the disc lesion and push superior with the thumb for 5 seconds while they're tractioning that leg. Sacral base, we've already covered that in a video. So next we'll go to the posterior blocking, sitting disc. I'm gonna have my patient sit up on a pelvic board, leaning forward with their hands on their knees. So we're gonna take these out. Sit up for me, quit texting. So I'm going to contact the spinous process at the level of the lesion. I'm going to have my patient inhale and flex forward and push their lumbar spine against my doc's thumb. And I'm going to apply I to S pressure on the spinous. Patient will then exhale and sit up, keeping their chin to their chest. Doctor will apply P to A pressure. Patient inhales, flexes forward, and pushes their lumbar spinous against the doctor's thumb. Doctor will apply I to S pressure. Alright, so side posture. I'm going to have my patient get in side posture. This is for a rotated vertebra. Sciatic leg must be the side that's down, so that's going to be the sciatic leg. So that means the spinous process is rotated toward that leg. I'm just going to put my patient in side posture. Here, I'm going to contact, is this where I contact the medullary? With 2 fingers? Alright, and I'm just going to apply a P to A thrust here. The next one is the inferior vertebra. So then I'm going to be at the popliteal fossa. And this is where I'm either going to use my Pisi or 2 fingers on the medullary and do a P to A thrust. It's a wrap.